Yeah. Oh, we done it though, because then I went to volleyball Thursday night and the other team. So fun. And they were
Okay, everybody, I think we're going to get started because there are some folks zooming in and they're waiting, so don't want to keep people waiting. But it is great to see some people here live. I'm glad some people were willing to brave the lull in the pandemic to come out here and get to see each other face to face, which is wonderful. I want to welcome you all to the annual State of the Department of Pediatrics address. Today, I want to discuss 3 issues. First of all, how to find purpose in our work. And I've been thinking a lot about this past year, given all the stress that everybody's under. It's such an important aspect of what we do. I want to summarize for you the tremendous progress that we've made as a department this past year. And there's so much that I could highlight that I'm not going to be able to mention everything and everybody. So I apologize in advance if I don't mention the great work you're doing. And finally, related to purpose, I want to give you some thoughts as to how we can bring some joy back to the practice of medicine. It feels like in recent years, that's been a challenge for us in the medical profession. And like I've done in previous years, halfway through my address, there'll be a quiz. So we'll see who might be able to come up with the right answer. Now, I don't know if it's just me, but maybe some of you also sometimes are wondering if you're accomplished anything worthwhile with all the work you do. I sometimes wonder if anything I do really makes any difference at all. If I fell under a bus tomorrow, the world would go on. I don't know if anybody would notice. Maybe my dog would notice. He wasn't getting fed, but probably not even my dog because my wife, Jody, actually usually feeds the dog. So I just look at some of the problems we're facing in our world today, and it just seems so overwhelming. And I sometimes feel, what am I actually able to do to have any impact at all? Take, for example, global warming. I could cover every square inch of my roof with solar panels. I could uh, drive an electric car. I could bring my carbon footprint down to 0. It would be one drop in a huge, massive problem that I don't think anything I do would be noticeable. Or what about provider burnout, which has been on my mind a lot and which I'm going to spend some time talking about later on in my address. I worry a lot about provider burnout and physician burnout because it's affecting so many of the members of our department. It seems to be getting worse all the time. But when I think of my ability to impact on this, it's a national crisis. It's a function of the dysfunction in our healthcare delivery system in this country. What can I or one single person actually do about that? And when I'm sometimes feeling down like this, I sometimes look to try to find inspiration from the philosophers of old because I find a lot of wisdom in actually some of those ancient writings. We tend to think that in our modern society, the ancients have nothing to say to us that has any relevance to our complicated world, but people are people. And they were wondering the same things back then, and we're wondering today, including what's the purpose of our existence? That's been a question that humans have been asking since the dawn of civilization. And one book that I find particularly inspiring when I'm feeling down is the book of Ecclesiastes, which was written some 3,000 years ago. It's a short book. You can read it in under an hour. And tradition teaches that it was written by King Solomon, who was considered the wisest man of his time. And I don't know who wrote that book, but I do know that whoever did write it must have been terribly depressed, terribly depressed. The book starts with the following sentence: meaningless, meaningless, everything is meaningless. Now, that's not exactly where you think I might go to find inspiration, right? But like a lot of things, the reward comes if you persevere. And if you stick with Ecclesiastes, inspiration does come at the end, as you'll see. He spends most of the book stating all the reasons life is meaningless. Everything's the same, nothing changes, there's no progress. He writes, the sun rises and the sun sets, and there's nothing new under the sun. And he goes on to say, all the rivers flow into the sea, but the sea is never full. And actually, when you think about that, that's actually a really interesting point. I don't know why exactly that is, but it's an interesting observation. And after describing a litany of reasons why life is meaningless and without purpose, he decides to embark on a search for purpose, hoping that if he looks hard enough, he'll find it after all. So he decides to accumulate knowledge, hoping that with enough wisdom, he'd come to understand life's purpose. So he spends years acquiring all the knowledge of the day until he was the wisest man of the time. And when he had acquired all that knowledge, he writes, the more knowledge, the more grief. The fate of the fool will also befall me. What then have I gained by being wise? So I hated life, because the work that is done under the sun was grievous to me, for everything is futile and a pursuit of the wind. Now, the first time I read Ecclesiastes, when I got to this point of the book, I almost gave up because I thought I'm going to have to kill myself if I keep reading this. But I persevered, and I'm glad I did because, as I said, inspiration comes at the end. But he continues, since he couldn't find any purpose in seeking knowledge, maybe there would be purpose. Maybe the purpose of our lives is to seek pleasure, to enjoy our lives. One of the famous statements in the book is to eat, to drink, and be merry. Maybe that's the purpose in life. But after pursuing pleasure, he concludes that pleasure also has no meaning. It creates nothing of value. You wake up after a night of pleasure with nothing to show for it except maybe a really bad headache. So he decides to accumulate wealth, thinking that maybe there he can find purpose. And he collects jewels from around the world, builds beautiful gardens and lush palaces. But when he had accumulated all that vast wealth, he realized that for all his possessions, the fate of the pauper was also his fate. You can't take your wealth with you to the grave. So finally, after despairing at finding any purpose at all, you get to the end of the book. And at the end of the book, he has an epiphany. And he realizes the meaning and the purpose of his life. What did he discover? I'll share that with you at the end of my address because persistence is good. But before I do, I want to spend a little time sharing with you the great progress that our department has had this past year. I want to remind you of the vision that I articulated for our department when I arrived here as a department chair 3 years ago, and that is to be the nation's premier academic pediatric program. And in order to achieve that, I challenged the department to try to achieve 3 goals: to be the regional destination of choice for children needing specialty care. And I specifically mentioned specialty care here, not that our primary care isn't a really critical part of our mission, it is, but in primary care, we have partners in the community that deliver primary care along with us. We don't have a need to deliver all primary care, whereas in pediatric specialty care, with very few exceptions, it's different than adult medicine. Almost all pediatric specialty care is delivered at academic medical centers and not in the community setting. So in our region, it's us, it's Stanford, and it's a little bit of Kaiser. And we need to make sure that any child in our region that needs to see a specialist can see a specialist in a timely way. So that's a big priority and goal. Second, for us to be the leader in research and education to improve child health. And the third goal is for us to be the transformative model for child health equity and outcomes. And we can't achieve any of this if our department's also not a great place to work. So we must invest in our people as well. Now, I'm fond of this saying by Ben Franklin, who said, vision without execution is a hallucination. And so we have to know how to execute on these goals. And so we've developed an execution plan for each of these goals. In terms of goal number 1, We're focused really heavily on improving access and growing volumes so we can reach more children who have need. In terms of our second goal, we're seeking to be a top 10 pediatric department in terms of funding for the National Institutes of Health is one of those benchmarks. And in terms of our third goal, we seek to become a national center of excellence and do all the things you see there to help us achieve that. Now let's kind of go through each of these one at a time and look at our progress. And in terms of our first goal, I want to acknowledge here Jim Wong, our Vice Chair for Ambulatory Services, who's been working really hard on this effort these last few years, along with, he's part of a task force that we created a few years ago. It's called our Ambulatory Optimization Task Force. We meet weekly with members of our department, along with leaders from the health system, from the ambulatory part of the health system, driving this goal. And we've been focusing really on three aspects. We've spent the first couple of years focusing heavily on scheduling with the goal, the aspirational goal of being able to offer 72-hour new patient access to any child calling to ask to see one of our specialists. And we haven't achieved that goal yet, but that's the goal we've set for ourselves in order to really be able to deliver the services that the children of our community need. If you're a parent, you know that if your doctor, pediatrician says you need to see a cardiologist or an endocrinologist or any sort of specialist, if you have to wait more than a few days, we're not providing the best service. Recently, we've shifted. Now that we've spent a lot of effort improving the scheduling process, we've shifted to making sure we have enough providers to see all those kids who need to be seen. So we're now accelerating recruitment of all the necessary providers to meet the unmet demand. So for example, we recently did an analysis that we need 4 additional pulmonologists and 4 additional endocrinologists to see all the kids currently who are in need, that there's a demand, that we're on an unmet demand. So the old way of doing things, the way we used to do it, we'd recruit, if we need 4, we'd recruit 1 this year, 1 next year, 1 the next year, et cetera. And by doing that, never get ahead of the problem. And so we've made the decision now to recruit, we need 4, we're going to recruit 4 now to try to address the problem immediately. And we're working to fully integrate services across both campuses, which is a really important part of this as well. And in order to do all that, we need to have adequate clinic support so our faculty can work productively, right? We need to have the number of rooms we need enough staff. So we're doing something very different than what we used to do here at UCSF, and that is we're working in very tight partnership now between the department and the health system to coordinate all this ahead of time, so that when the provider shows up, the staff are there ready to go. Show you some of the progress we've made. You're looking here at our growth in our specialty volumes on the left and our general pediatrics volumes on the right. You can see that we had a little dip in FY20 at the height of the pandemic, but other than that, we're seeing steady year-over-year growth, which means it's good, means we're reaching more kids. And our general pediatrics volumes have been pretty much stable. They've dropped a little bit the last couple of years, again, probably because of the pandemic, but are starting to recover. But the not so good news is this, and I don't want you to look at all, this is a very kind of busy slide. Don't pay attention to all the details, just the big picture. Step back. The orange bars represent our Oakland clinics. The blue bars are San Francisco clinics. The red lines across the middle show you the percent of patients that we're able to see within 14 days. I'm not talking now about 72 hours. I'm talking about 14 days of them calling us. And you can see from this that we haven't made a lot of progress and we still have a long way to go. So that's going to challenge us in the next couple of years. And it's not just the volume of patients we're seeing. We also provide world-class care. I could point to lots of different examples, but this year I'm going to give you one example, and that's the new division of pain palliative integrative medicine that we established this year under the leadership of Dr. Stefan Friedrichsdorf as division chief. Stefan, good to see you in the audience. This is the first division of its kind in the United States, and Stefan is one of perhaps the world leader in this area, and having him at UCSF will enable us, really puts us on the map, being at the forefront of this. In terms of our goal to be the leader in pediatric research, I want to acknowledge our 3 vice chairs, Kevin Shannon for laboratory research, Roberta Keller for clinical and translational research, and Naomi Bardock for health services research, which is the new vice chair position that we've created. And then in our education leadership, Sandrain Van Schaik, our vice chair for education, Meg McNamara, our residency director, and Erica Lawson, who's new in the role of a medical student clerkship director this year. And we're pushing forward with our goal to be top 10 in NIH funding. And we've made some really good progress here, which I want to share with you. You see our year-over-year growth. Back in FY19, when I first arrived, we were 21st of all departments in the country. We've gone up to number 15 now. So we're halfway to the goal of top 10. And you can see there's been a dramatic growth in the funding that we've received from the NIH to the tune of $6 million this past year. And even more impressive is if you look at our total research dollars, NIH and non-NIH, you can see that we've had this dramatic growth over the last few years. Back in FY19, we were bringing in $40 million of extramural support. This past year, we had over $70 million, and 127 of our faculty are doing extramural research. So this is a real tremendous achievement and an example of how hard our faculty are working. And I want to congratulate all of them who are participating in these collective work. How we're going to continue to advance that goal is by recruiting more faculty to come to join us here at UCSF who are doing research, as well as to develop our young trainees and invest in their career development so they can be successful researchers, and also enhance our education programs. I'll share with you that we recruited 2 outside researchers this past year. Serene Avagnan, who's joining us from Harvard Medical School. She studies stem cell biology, and I want to congratulate Chris Dvorak, who recruited her here along with the help of Tibby McKinsey and the Institute for Regenerative Medicine. And then Laia Ekalspor, who Maya Lodish recruited to join the Division of Endocrinology from Stanford. And Laia studies using technology to monitor blood sugar levels in children. And then in terms of our young investigators, 5 of our trainees joined our faculty this year as junior faculty. Aika Erkin-Kakmak in endocrinology, Cheryl Peretz in oncology, Marie Cornett in neonatology, Jana Mike in critical care, and Anya Levinson in oncology. And we're really excited about continuing to invest in these young faculty so that they can achieve their goals of becoming leaders in pediatric research. Some of the ways we're supporting our young investigators: we've developed a department mentorship policy. We started a Frontiers, a seminar series where these young faculty get to present their research to their peers. Thanks to the hard effort of Jeff Feynman, we are one of 12 departments of pediatrics in the country that now is participating in this very competitive NIH K program. And for those people who don't know what K awards are, those are the first type of grants that a young faculty member gets from the NIH. It's a career development award, so it's a mentored grant. And our K-12 now supports 3 of our faculty. We're supplementing the salaries of our faculty who have K awards so they can be protected to develop their research programs. We started K faculty advisory committees to make sure that these young people are getting the support and guidance that they need. And we have a record 20 faculty now with K awards in the department, which has got to be one of the largest number of K awardees of any department in the country. I want to congratulate these individuals. 2 of our faculty received their first their own K awards this year: Stanley Vance from adolescent medicine and Sharad Watwani from gastroenterology. And though that transition then from going from being in a mentored K award to becoming an independent investigator means getting what's called an R01, NIH R01. That's a critical milestone. And congratulations to Shape Vandi, who this year made that transition and got her first R01. We're working to enhance our education programs. Year over year, we're ranked number 4 or 5 in the nation by US News Report in terms of our residency here in San Francisco. Our education group published over 25 papers this past year. And we've initiated monthly educational skills development workshops for everybody who supervises and teaches learners in our department. And I want to welcome the wonderful young trainees who joined us this year. You see our 31 pediatric interns and our 33 new pediatric fellows. These are the future of our pediatric specialty. And so we're delighted that they're here with us training at UCSF. Some of these people are going to go on to become leaders in the field of pediatrics. Turn of our effort in child health equity, our third pillar goal. I want to acknowledge our leaders in this area, Anda Kuo, who's Director of Child Health Equity and Community Engagement, and also co-directs, along with Dana Long, the Center for Child and Community Health. Raul Gutierrez, who oversees our PLUS program in our pediatric residency, and Alma Martinez, who's our Vice Chair for DEI. We're doing so many things along the line of DEI, and I'm going to just highlight one example of that for you. And that is something that Maya Lotish started, which she calls NICH, which stands for Novel Interventions in Children's Healthcare. This is a really exciting program. It was launched in 2020 to help youth facing both chronic medical conditions and significant psychosocial vulnerabilities, because you can actually predict, when you've got children with chronic illness, you can predict who are the kids, oftentimes, not always, but oftentimes you can predict who are the kids who are going to have the most bad outcomes and the highest utilization of cost to the healthcare system and utilization of healthcare by the zip codes they live in. And so even though these kids represent a very small percentage of the total pediatric population, their risk of life-altering complications is quite high, and their cost to the health system is quite high. And so the program that Maya has developed involves creating individuals that are referred to as interventionists who interact with these patients on a daily basis, providing 24/7 family access, home and community-based services for a year, so that these kids get the services they need. And Maya, thank you, Maya, for sharing with me some of the early outcome that is really impressive from this program. This is some data, preliminary data, using now children with type 1 diabetes. And you can see the blue is pre-enrollment in NICH, the green is post-enrollment in NICH. The mean days in the hospital has gone down. The mean cost per patient per year has gone down. The mean hemoglobin A1C has gone down. That's a blood test that measures patients' blood sugar control. And the use of glucose monitoring, continuous glucose monitoring, which is standard of care now, has gone up dramatically. Now, Maya is working with government entities to try to partner with them so that we can expand this program to children with other sorts of chronic illnesses and not just diabetes. I'm excited about the future of this program. As I mentioned, we need to be investing in our people, and I want to share with you some of the great things our people have done this past year. First of all, this department is committed to DEI in all its forms, and we are investing this year over $600,000 in various DEI initiatives. I'm just going to highlight one today, again, in the interest of time. This is a program that Alma Martinez launched this year called our Junior Faculty Leadership Program, which supports 4 of our junior faculty, each being provided with 10% protected time to develop projects in DEI. And the 4 this year are Laura Rubinos, who's working on mentorship for UIM trainees, Bianca Argueza, working on trainee pipeline programs and growing department participation in the summer student research program, Mari Tamarat, working on improved patient and MyChart experience at the Oakland FQHC, and April Edwell, working on DEI curriculum and learning environments for trainees supporting the RISE Coalition. We had a whole group of faculty promoted this year, and I want to congratulate all of them, and I'm going to mention each of them by name. Promoted to Associate Professor, Lisa Arcilla, Nia Basin, Alice Chan, Mansi Desai, Rafael Ernesto Diaz Flores, Naha Lilafar, Megan McGarry, Melissa Medvedev, Alexis Melton, Preeta Mohanty, Vivian Nguyen, Kavita Pundi, Marissa Raymond Flesh, Stanley Vance, and Kihoa Tran Vo. And then promoted to full professor, Sabina Ali, Sanjeev Dattar, Susan Kim, Jennifer Mishlich, Martha Douglas Escobar, Marsha Lee, Simon Lee, Amy McNellis, Brian Feldman, Maud Doe, Farzana Purwad, Lynn Ramirez, Angela Rivers, June Tester, Ben Braun, Malasetti, Robert Raphael, and Joseph Shea. So congratulations to all of those people for their career advancements. We also have, our faculty are nationally and internationally renowned for what they do and the excellence and their reputations. And I could be here all day if I'm going to mention every one of them. So I'm just going to mention a few highlights of what our faculty were recognized for this year. Elena Fuentes Affleck, who were named Vice Dean of the UCSF School of Medicine at ZSFG and appointed to the editorial board of JAMA Pediatrics. Jennifer Puck, who received the Precision Medicine World Conference Pioneer Award. Joanne Young, elected to the Executive Committee of the Council on Health, Mental, and Emotional Development at the American Academy of Pediatrics. Stephen Rosenthal, elected to the Board of Directors of the World Professional Association for Transgender Health. Sabina Ali, elected to the Board of Improve Care Now. Lee Atkinson McAvoy, elected President-elect of the medical staff here at UCSF. And then Fernando Gonzalez and Roberta Keller, both elected to the Society for Pediatric Research Executive Council. We had a number of faculty elected to other prestigious societies, to the AAP, Phil Rosenthal, to the SPR, Teresa Kortz and Onur Sil, and to the APS, Fernando Gonzalez, Sarah Buckaloo, and Glenn Rosenbluth. And we had a record 9 of our faculty who were elected this year to the UCSF Academy of Medical Educators: Celeste Allen, Carmen Cobb Walsh, Eddie Cruz Romero, Mansi Desai, Valerie Gribben, Efrat Lelkis, Laura Rubinos, Dina Wallen, and April Zad. So congratulations to them. Our faculty are also publishing huge number of impactful papers in prominent journals. I'm going to show you just 2 examples of some of that great work. The first was led by Matt Zinter, who was first author on this paper, along with, you see, other members of our department, as well as Joe DeRisi, published in Science Translational Medicine this year, showing that pulmonary function in children undergoing hematopoietic cell transplant had microbial deletion that was associated with abnormal pulmonary function. And then the second paper, with Mary Prahl as first author, along with her colleague Valerie Flaherman, published in Nature, showing that mRNA COVID vaccines are safe in pregnancy and generate protective functional antibody response, both in the mothers as well as in the infants. We welcomed 40 new faculty to our department this year. Take a look at the growth in the size of our department just these past 3 years. We've gone from 278 faculty to over 400 faculty. We're now one of the largest departments of pediatrics in the country. We appointed 6 new division chiefs this year. I mentioned to you Stefan Friedrichsdorf. We also have Shonul Jain, appointed interim chief of service at ZSFG, Suni Kaiser, chief of hospital medicine, Joy So in medical genetics, Alejandro Sweet Cordero in oncology, and Mark Walters in hematology. All 6 of these individuals have tremendously exciting visions for where they want to take their divisions. And I'm excited and enthusiastic about helping them achieve these really ambitious goals that they've set out. Okay, every year I like to acknowledge 2 individuals that I call our unsung heroes. These are outstanding faculty who don't always appear in the limelight. They're not necessarily publishing the big papers in the New England Journal or getting the big grants, but they're doing hugely important work quietly, without a lot of commotion, that has tremendous impacts on our community. And I want to acknowledge 2 individuals this year, both of whom work in the area of child abuse, which is caring for the most vulnerable, amongst the most vulnerable of the children we care for in our programs. And the first of these is Chris Stewart. Chris was the first pediatrician in San Francisco to be board certified in child abuse, cares for children at ZSFG and Lucille Packard as well, conducts forensic medical evaluations for the city and county of San Francisco, directs child abuse rotation for medical students and residents, directs the global health education programs at UCSF, and he works across the world including Vietnam, Democratic Republic of Congo, and other places where he administers training programs in child and physical and sexual abuse. And then his partner in Oakland, Jim Crawford, who has for over the past 30 years cared for children who are victims of child abuse. Jim leads the Center for Child Protection at Benioff Children's Oakland, sees over 1,000 children a year. He's received numerous distinguished awards, including from law enforcement, child protection services, the Department of Justice, and the American Academy of Pediatrics. So let's just take a moment to applaud and acknowledge the great work that these heroes have done. Okay, we've gotten to the point where it's time for the quiz. So I'm going to ask you a question. It relates to the theme of meaning and purpose. And let's see if there's anybody in the audience who can give me the answer. Quote about the purpose of life. Who said the following? I did the best I could with what I had. And to make it a little bit easier, I'm going to give you a hint. It's one of the following three people. Was it Robert E. Lee, commander of the Confederate Army? Was it Donald J. Trump, the 45th president of the United States? Or was it Joe Louis, the world heavyweight champion? Anybody want to take a guess? That is great. You are an impressive, who was that? Anda? Oh, Roberta. Well, I think you know me pretty well. That's right. It was Joe Louis, who had to endure much racism and bigotry during his life and his career. He was born in the Deep South, an impoverished Black kid with no education to speak of. And for the pediatricians in the room, you'll be impressed to know that at birth, Joe weighed in at 11 pounds. So he was destined to be a bruiser from his birth. In 1937, he won the title, and he rose to become one of the greatest heavyweight champions of all time. And even during the glory of those 12 undefeated years where he defended his title an astonishing 26 times, he was a man of few words. So when he was asked upon his retirement about his long career and what made him successful, he sweetly summed it up in these 10 words. I did the best I could with what I had. And you can't describe the meaning of life or the purpose in life any better than that. Okay, so I want to return back to the idea of purpose and how we can bring joy to the practice of medicine, because something big is happening. I think we all kind of feel it in our world. The world feels like it's in upheaval. Everyone and everything seems to be under stress. Our politics, our technology, our relationship to work, our views on race and ethnicity. And it's not just the pandemic. The pandemic has exacerbated some of these trends that have been going on for a while now. We're going through, in my opinion, one of these multi-generational shocks that entirely disrupts human society. Like the Renaissance, the industrial age, we're in some sort of new disruptive age that doesn't yet have a name. And medicine's not spared from that revolution. I've been in academic medicine for 40 years, and I'm used to the ups and downs, but I've never felt what I'm feeling now. This feels different in a foundational way, and it's causing huge stress on our healthcare delivery system. And doctors, as you all know, are experiencing more stress than any other profession. There was an article published last month in Mayo Clinic Proceedings that actually got to the New York Times, headline in the New York Times. 63% of physicians report at least one symptoms of burnout this year, and it was 44% 5 years ago, and only 30% feel satisfied with work-life balance. A few months ago, I was speaking to one of our senior faculty in our department who came to visit me during my office hours, and she said to me, I no longer feel joy at work. I'm so harried throughout the day, and I come home so exhausted that the joy has been squeezed out of being a doctor. And I've been thinking about that conversation for the past few months. Not only was it deeply disturbing to me, but it got me to wondering again about what's causing all that and what can we do about it. So in the remaining time in my address, I want to spend a little time sharing with you some of the thoughts I have about what got us here in the first place, and what the promise is and the hope that things will be better. Because I am optimistic that things are going to be better. I don't know if anybody's read this book, Atul Gawande's book, Being Mortal. Anybody read that? Read this book? I highly recommend it. It should be required reading in all medical schools. Dr. Gawande writes as follows: we've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really, it's larger than that. It's to enable well-being. And well-being is about the reasons one wishes to live. What are your fears and what are your hopes? What are your trade-offs you're willing to make and not willing to make? Now, that sounds like a great way to practice medicine, doesn't it? But we'd all like to do that. But as that faculty member told me, we're drowning in demands. It feels like we're harried every minute of the day between the RVU efforts we need to achieve and the electronic medical record and the in-basket. Who's got time to practice medicine that way? Well, it didn't used to be that way. Medicine used to focus on the well-being of the entire patient, bringing the value of things such as faith and hope and compassion into the healing process. And I want to give you some hope that I think those days are coming back. I am optimistic. But first, to understand where we go from here, we need to understand how we got here in the first place. And so I want to take you on a very short kind of journey through the history of medicine in just a very brief, high-level view. So if we go back to early recorded history, illness involved the mind, the spirit, and the body. That's the way the ancients thought about illness. You got sick because you made the gods angry. And so treatment was focused on appeasing the gods, prayer, repenting, etc. And at some level, we still believe that today. You know, we bargain when we're ill and we make promises if only we'd get better. And then into this world came Hippocrates, who introduced the concept that illness was not from angering the gods, but rather that it was due to natural causes. And he also brought into medicine the concept of ethics, the Hippocratic Oath. It states that the good of the patient is the end all and be all of how we should practice. And then came Aristotle, who taught, he kind of looked at the different organs, and he taught that the liver was the source of, was related to food. The brain was responsible for motion. And this was just an observation that people had, that if you hit somebody hard enough on the head, they stop moving. So the brain must be related to motion. And Aristotle introduced the concept that the heart is the source of spirit, the source of life, the source of feeling, of passion. And as you all know, to this day, we attribute those ideas to the heart, right? And for the next 1,000 years in Christian Europe, treatment was mostly spiritual. It was prayer, priestly intervention, pilgrimage, penance. And meanwhile, in the Arab world, Arab scholars had developed surgery, therapeutics, and medicines. And in the first part of the second millennium, these two ideas, healing the spirit and healing the body, merged where the Christian world and the Muslim world came together. One place, for example, was in Siena, Italy. Back in the 11th century, this hospital was founded. The Ospedale di Santa Maria delle Scale functioned as an actual hospital until 1930. Here they cared for the spirit and the body. It was set up by the church to treat the poor, the Christian church. And here's a mural that's in the building. And you can see here a patient's being treated. You can see a big gash in their thigh. But you can see that the wound is not yet being attended to. First, there's a man washing the patient's feet because touch is important to healing. And you can see behind him, there's a person tenderly draping a blanket over him, recognizing that attending to the spiritual, emotional, and mental aspects of his injury are every bit as important as attending to the wound. And behind him, there's another patient that's being gently laid down on a bed. And all the way over to the right, to my side here, is the surgeon waiting to operate until the patient is first comforted. Now, here's another mural from the building where showing that patients, when they were discharged, they were each given a new set of clothes, even though these were the poor, not secondhand clothes, out of respect for their spiritual dignity. And then came this man, William Harvey. And William Harvey made a fundamental discovery that changed the course of modern medicine. But that discovery, as great as it was also responsible in a way for us losing our focus on the mind and the spirit and shifting our focus in medicine strictly to the body. Because what Harvey discovered was the accurate circulation of the blood. And that the heart, which since the time of Aristotle was thought to be the source of the spirit and of emotions, he discovered that the heart was actually just a mechanical pump. And this had a great impact at the beginning of the 18th century, the period we call the Enlightenment, because at that time, a new concept arose that we should separate the humanities from the sciences. So religion, music, literature, art, all those things that were hard to define fell onto the humanities side. And then on the sciences side, physics, chemistry, biology, the things you could observe and measure. And medicine fell firmly into the science side, leaving behind the humanity of the individual. And what followed was an organ-centered medicine, increasingly focused on specialization, cardiology, nephrology, ophthalmology. People specialized in those things, and who was left then to treat the patient and the spiritual needs of the patient. Students were admitted to medical school purely on the basis of their scientific knowledge. Communication skills were devalued. Knowledge of the humanities was devalued. And in large part, this is the world we still live in today. But we have the opportunity now, ironically because of technology, to regain what was lost since William Harvey discovered that the heart was just a pump. And from a place that might surprise you, and that is the rise of artificial intelligence. And if you haven't been paying attention to this, you're missing one of the most exciting chapters in the history of medicine. I believe that this is going to make our lives and our practice and our profession better. And totally by coincidence, this past Friday, I don't know if anybody of you saw Ezekiel Manuel gave grand rounds in the Department of Urology, and he gave his grand rounds on the promise of AI to transform how we practice medicine. So all I can tell you is we were not coordinating any of this, but it does point out that there's a lot of people now thinking about this area. It's becoming a really big area. People who are studying AI are predicting that within 5 years, maybe 10 at the outset, much of the traditional work of a doctor will be replaced by machines, by artificial intelligence devices that can do it faster and arguably better. The problem with Epic, for example, is that it was never designed to help, which is the bane of our existence, as you know, was never designed to help doctors practice medicine. In fact, it was never designed for doctors. It was designed to help hospitals with billing and scheduling. And the helping doctors part was tacked on as an afterthought, and it's never been a very good fit. But these new AI tools are being specifically designed to improve how doctors and practitioners practice medicine. And that's one of the reasons I feel optimistic about its potential, because we humans are a pretty clever species, and some very creative people are applying their creative minds to this problem. And the optimists think that AI can help us reach a golden age in medicine, freeing up doctors away from the mundane work we do to concentrate on the kind of things I was just talking about a moment ago, tending to the mind and the spirit, and not just the body, to our relationships with our patients, to what I call the joy of healing, like at the beginning, but even better, much better, because we'll have the knowledge that the ancients lacked. Part of what's driving this is, frankly, just the sheer volume of medical information. This just shows you a slide. This slide's actually a few years old now, but just shows you the exponential growth in the sheer volume of information that we need to process as practitioners in care of our patients. Healthcare data doubles every 24 months. There are 24 million articles in the medical literature and close to 1 million new articles being published every year. Who's got the time, let alone the brain processing power, to be able to manage and learn and put all this information into the care of patients? It's a big data problem, actually. No person is brilliant enough to be able to absorb all this, but an AI device can do it within seconds. So what if sifting through all of this big data was done for you as a physician and you were presented with the bottom line? If we break down the process that a physician goes through with a patient, it's fundamentally about processing information and pattern recognition, which AI is ideally suited for. So we gather information, the history, the physical, the labs, imaging. We then go through a process of pattern recognition to make a diagnosis. And then we make a treatment decision based on the knowledge we've acquired during the course of our career, as well as our ability to know what the literature has to say related to that patient's diagnosis. And although some of us may not want to admit it, we're actually fallible in each of these things. Physician errors kill 200,000 Americans annually, and the misdiagnosis rates are at least 10%. So if we look at this, already a lot of this is being done by machines. History, a lot of the history now is being entered onto computers before we even walk into the room. Soon you can imagine a supercomputer AI device collecting the history, asking the right questions. They're learning now, these AI devices are so sophisticated, they're learning to recognize faces and even recognize emotions on faces. Well, labs are already being done by machines. Unless you're a nephrologist, when was the last time you looked at a urine sample under the microscope? And even if you're a nephrologist, I'm not sure when the last time you looked under the microscope at a urine sample. Imaging is already done by machines and interpreted by machines. Diagnosis, as I mentioned, it's basically pattern recognition, which AI is very good at, better than humans. And medical knowledge, who's going to keep up with 1 million new journal articles every year? And what about the physical exam? I know some people might think, well, okay, maybe AI can do these other things, but it'll never replace the ability of a physician to examine a patient. Anybody remembers Star Trek? I don't know, I used to watch a lot of Star Trek, but there's Dr. McCoy with his tricorder. Remember, he never touched a patient. He just scanned the patient with his tricorder, and in a few seconds, his exam was complete, and he had the information he needed. And that's something that's interested me for quite a long time. I'm a rheumatologist, and rheumatologists are convinced that we're highly skilled at examining the joints. But this has been studied and published, numerous publications, that we actually are pretty bad at it. So if you take a group of rheumatologists and ask them to examine the same patient, they can't agree amongst each other as to whether a joint is arthritic, it's inflamed, let alone the severity of the inflammation. And even if you blindly take the same rheumatologist and ask he or she to examine the same joint blindly, that rheumatologist can't agree with his or her own exam of the joint. So 15 years ago, when I was at the University of Pittsburgh, Children's Hospital of Pittsburgh, I was intrigued by this. And I was curious whether there's a more objective way to do a physical exam of the joint, since we're so bad at it and it's so subjective. Well, if you remember from medical school, actually the Greeks developed the 4 cardinal signs of inflammation: dolor, calor, rubor, and tumor. Pain is subjective, but the other ones actually are amenable to being quantified and imaged using technology that's referred to as machine vision. And so I went down the street to Carnegie Mellon University, where some of the world leaders in robotics work. These are the people that designed the rovers that are driving around Mars. And we applied machine vision to this problem of doing a physical exam for joints. And we created this prototype. We actually started a company to try to advance this, where we combined a thermal imager, thermal camera, and 3D cameras to create surface modeling of the joint of the hand, where you can actually isolate each joint one at a time, and you can look at pre and post. So here's an example of a wrist that's swollen. You can hopefully see the arrows pointing to the swollen wrist on the left, and then after injection with steroid, you can see the swelling went down. So you can look at that with your eyes. But on the right, we can actually measure the volume of that swelling and the change in volume, the change in shape. And down below, you can see the change in warmth, going from warm to cool. Now, this device of ours is primitive compared to what's available nowadays and what will be available in the coming years. And I'm convinced that the day will soon come when we'll have devices that will be able to help us perform the physical exam better and more objectively than we can do. And we will have devices like Dr. McCoy's tricorder. And imagine if you have your own personal assistant following along with you all day long, not getting tired, not getting irritated, collecting the history for you, scanning the body for the physical findings, taking all that information, searching the literature, and coming up with a likely diagnosis as well as a suggested treatment. And best of all, putting all that data into the electronic medical record so you don't have to waste your time doing that. Think about how much time that's going to save you and how much time it'll free up so you can go back to actually spending time with your patient. And if you think this is just science fiction, that's going to, it's years and years in the future. Right now, here at UCSF, our faculty practice office, which oversees all ambulatory services at UCSF, is in discussions, is actually contracting with an AI scribe company that has developed a platform for having AI do scribing rather than people, because with people it's been less than optimal. Turnover rate of scribes is very high and it's hard to train them. And we're going to be piloting this AI scribe platform here at UCSF in the very near future. Just to give you another example of how unbelievably powerful this AI technology is becoming. This was an article in the Washington Post just a few weeks ago talking about this device called DAL-E, which is a text-to-image generator. Basically, you can type something into it or speak into it and ask the AI device to create an image of what you typed or spoke. So here's an example. Protesters outside the Capitol building on January 6, 2021, AP style. That's what was the device was asked to make an image of. And there's the image. This doesn't exist in the real world. This is a totally made up image. It's actually kind of scary when you think about all the fake news we're living in today, when you can artificially create something this realistic. What does it mean in terms of our ability to know what's fake and what's real in this world anymore, when people can make these sorts of images? I'm kind of frightened by that. There's another example. The machine was asked to create a woman in a red coat looking up at the sky in the middle of Times Square. This is not a real image. This is a made-up image. A model photographed by Terry Richardson. Red and yellow bell peppers in a bowl with a floral pattern on a green rug photo. So that's pretty incredible, and just gives you a taste of where this technology is heading. So it leaves us wondering, if AI is going to do all that, what's left for the doctor or the nurse or the social worker? Well, there's one thing that AI will never be able to do, and that's hold a patient's hand and know how it feels to be human, because no AI can empathize. Grateful patients don't thank you for making the right diagnosis. They thank you for your kindness, for your caring, for your empathy, for helping them deal with their child's illness. I think this is actually the world of the future, the combination of using these extremely powerful technologies combined with human empathy. Now, you may think this might dehumanize the practice of medicine, but I actually think if we want to be optimists, and I'm an optimist, it will return the medical profession to what it was at the beginning, caring for the totality of the patient, the mind and the spirit, and not just the body. And so as we consider this future, I want to end by returning finally back to the book of Ecclesiastes. Thank you all for your patience. And I want to share with you the inspiration that the author found at the end As you remember, he was desperately looking for a purpose in his life and finding none. And then at the end, in a moment of insight, he realized the purpose of his life. And here's what he wrote at the end of his book. Whatsoever your hand finds itself doing, do it with all your might. That is the purpose of our lives on earth, because we're transient beings. Our candle burns for a brief time and then we're gone. We don't see the whole picture. We see only fragments. Wisdom, pleasure, wealth, they're all fleeting. But the work of a person outlasts the life of a person. And it's in that work that we create purpose. And that's the triumph of the human spirit. 10 years ago, when I was leaving Children's Hospital in Pittsburgh to move to Iowa to become the chair of pediatrics at the University of Iowa, a few weeks after I left, I got a big manila envelope from my secretary in Pittsburgh. She had sent me a bunch of mail that she was forwarding to me that came after I left. Mostly it was junk mail. But mixed in that junk mail was a card from one of my patients, a girl of 14 with juvenile arthritis, who I'd been treating for a number of years. And she wrote, "Dear Dr. Hirsch, thank you. I'll never forget how you helped me with my arthritis. Because of you, I feel I have a future." And I was frankly shocked at this card because this was my most non-compliant patient. She didn't take her medicine. I never knew if she'd show up for clinic. Her arthritis was not in control. She seemed totally uninterested in her disease. I felt that I completely failed this young girl. And I'm sure the same is true for each and every one of you. You may not realize the impact you're having on others, but sometimes it's the things you feel are the least impactful that actually are the most impactful. That one patient that you were able to help, the one student that you influenced, the one little discovery you made that only one person reads your paper, but that leads to another discovery. The trainee or the faculty member that you helped accomplish one of their projects. If you're a member of our board at the hospital, you contributed something to the discussion. It does make a difference, even if you can't see it. And the truth is, you'll never know the full extent of your impact because nobody will tell you. But I assure you that it does make a difference. It's too bad in a way that we can't listen in on our own funerals, because we'd have a chance during the eulogy to hear about all the great things we did in our lives that nobody told us while we were alive. So whatever you're doing, as Ecclesiastes taught, do it with all your might. That thing that you do, that little thing that improves one little corner of the world, it ripples out in ways that you can't imagine. What greater purpose can there be than helping another person? The ancient sages taught, whoever saves one life saves the entire world. And so I want to thank each and every one of you for what you do every day. Each of you sets an example of what it means to live a life of purpose. I know that because every day as I walk through this department, what I see is people following this dictate of working with all your might, with all your commitment, with all your passion. That's why our work has purpose. That's why we'll be successful. That's why what we do is transforming medicine, our community, and yes, even our own lives. I want to congratulate you on all the wonderful achievements of the past year. And as fabulous as those achievements have been, I believe with great confidence that our best days are ahead of us. Thank you all. And I now want to invite you to our reception, which is right outside the room here, where we have some refreshments for all of you, and we'll have a chance to greet each other and share, spend some time together. So please